There are two types of intervertebral joints to discuss. The zygapophyseal joints are found along the posterolateral columns between the superior and inferior articulating facets. These are planar synovial joints that permit a certain degree of gliding during flexion and extension. Because of the arrangement of these joints in a near sagittal plane, rotation is somewhat limited between vertebrae. In contrast, the intervertebral joints are fibrocartilaginous joints found between the vertebral bodies. Rather than a joint space, which is seen in all types of synovial joints, the vertebral bodies are instead connected through a fibrocartilaginous intervertebral disc. The structure itself resembles a jelly-filled donut. The inner core or jelly of the disc is made of gelatinous glycoprotein matrix called the nucleus pulposa. This provides distensibility of the disc and, as we will see, acts as something of a ball bearing for multiplanar movements. The outer cortex of the disc, or pastry, is made up of a series of concentric rings of connective tissue known as the annulus fibrosus. This provides the disc with its rigidity and contains the inner pulposa. Note that the annulus fibrosus is not uniform along the perimeter of the disc. The nucleus pulposa rests closer to the posterior aspect of the disc, where the annulus fibrosus is thinner. As we will see, this has clinical implications related to disc injury. The donut analogy is quite useful, actually. Here we can see that when a jelly donut is compressed between our hands, the weight is dissipated in all directions. This is the reason for the well-understood fact that our weight decreases throughout the day and why distraction provides temporary pain relief from compression-type injuries. We're also able to see how the inner core can be pushed to the periphery through 360 degrees, creating temporary wedge shape within the disc. This allows for bending of the vertebral column in any direction. Limitation of different parts of the column is dictated by the orientation of the zygapophyseal joints. Finally, the inner core would permit a small degree of twisting of the upper portion of the disc relative to the lower portion, accommodating rotation of the intervertebral joints along this long axis. I would demonstrate it in the video, but I had forgotten about that segment and had already eaten the donut. These joints are reinforced by a number of strong ligamentous structures. The anterior longitudinal ligament lies at the very front of the vertebral bodies and is best viewed from the abdominal cavity once the parietal peritoneum is removed. It is a broad, vertically running band that provides the only ligamentous resistance to hyperextension. Lying on the dorsal surface of the vertebral column, anterior to the spinal cord, is the posterior longitudinal ligament. This thin band complements the anterior longitudinal ligament by limiting flexion of the vertebral column. Together, these bands also reinforce the intervertebral discs by limiting anterior and posterior disc protrusion. As the name implies, the supraspinous ligament runs longitudinally along the upper margin of the spinous processes. It blends with the segmentally arranged interspinous ligaments running between the superior and inferior surfaces of adjacent spinous processes. Together, these ligaments assist the posterior longitudinal ligament by resisting separation of the spinous processes during flexion. Deep to these ligaments along the anterior surface of the vertebral arch is the ligamentum flavum, meaning the yellow ligament. The yellowish appearance of this ligament is attributed to the high quantity of elastic connective tissue that makes it up. The segmentally arranged ligamentum flavum provide little resistance to column flexion. Indeed, the high quantity of elastic connective tissue means that these ligaments stretch during vertebral flexion. They play a greater role in assisting in a return to an extended position due to the elastic recoil in these ligaments. We finished this first presentation with a discussion of a few conditions related to the intervertebral and zygapophyseal joints. The first is related to the intervertebral discs. As previously described, the gelatinous core is reinforced by the annulus fibrosus. So what happens in this situation when compressive forces exceed the strain limit of this reinforcement? Well, the same thing that happens to a jelly donut. With excessive force, the outer pastry ruptures and the jelly contents protrude from the ruptured point. With the innards protruding out, the donut looks, well, somewhat flat, doesn't it? We see the same situation with vertebral discs. With excessive axial loads or weakening of the discs, there is the potential for the disc to rupture, resulting in a herniated disc. The most susceptible point is the posterior region of the disc, where the annulus fibrosus is the thinnest. The nucleus pulposa thus projects posterolaterally, being partially deflected by the presence of the posterior longitudinal ligament on the back of the vertebral bodies. This can result in compression of the cauda equina, or more commonly, because of its lateral deflection, of individual spinal nerves, resulting in radicular pain symptoms. The specific nerve root that is affected is worth noting. In the lumbar region, the spinal nerves exit intervertebral foramina formed superiorly by the vertebrae they are named for and inferiorly by the vertebrae that is one greater. For example, the L4 spinal nerve exits between L4 and L5 vertebrae. With this being the case, we would initially expect that a disc rupture between the L4 and L5 lumbar vertebrae would compress the L4 spinal nerve. In fact, what we observe clinically is that the L4 spinal nerve exits high in the intervertebral foramen, above the site of the herniation. Consequently, what is more commonly observed is direct compression of the L5 spinal nerve in this situation. Thus, a general rule for lumbar disc protrusion is compression and radiculopathy of the spinal nerve named for the lower vertebrae rather than the higher vertebrae. This doesn't mean that the L4 vertebrae will be completely spared, however. With protrusion of the L4 nucleus pulposa, we would expect a decrease in the height of the L4 intervertebral disc, and consequently of the L4, L5 intervertebral foramen. This could have the potential to still cause an L4 radiculopathy. One of the treatment options available with compromise of the vertebral canal or spinal stenosis One of the treatment options available with compromise of the vertebral canal, or spinal stenosis, is a laminectomy. As the name implies, a portion of the lamina is removed. This allows for a posterior expansion of the contents of the vertebral canal to alleviate some of the pressure placed on the spinal cord or nerves